Can you see my screen right now? If you let me check. Okay. So let's start with the D-dimer. So as you know that in the D-dimer, we have a four-part. The first part about what is D-dimer, or what is homeostasis, and the introduction of the D-dimers. And in the second part, we will discuss about the clinical application of the D-dimers in different diseases, how we can use this tool as an prognosis tool. It's the most sensitive, but it's about the specificity that can be ruled out with further supplemental testings. And in the third part, we will talk about the marketing strategies and the marketing dynamics for the D-dimer assay. And in the last, there is question answers few related to that D-dimers. So let's start with the introduction of D-dimers. So if you talk about the D-dimer, as you know that, okay. If you talk about the D-dimers, you know that this is basically a marker for coagulation and fibrinolysis in the hematostasis stage. There is a normal physiological condition in which the coagulation and anticoagulation systems are in a dynamic balance. So if we talk about the coagulations, there are few clotting factors like thrombin-activated fibrinolysis inhibitors, alpha-2 macroglobulin, alpha-2 antiplasmic factors. They have during their strokes, myocardial infarction and thrombosis, and DVT and PE cases. These are playing a very vital role. If we talk about the fibrinolysis, the breakdown of the fibrinogen, and they play a very important role in the degradation factors like antithrombin, factor 11A, 12A, kallikrein, urokinase, tissues plasmogenase activators, and plasmogen activators inhibitors 1 and 2. Usually during the major surgery and trauma and hemophilia cases, these are fibrinolysis statuses progress. So if any question you have, yes, okay, thank you. So if it goes to the next about what is D-dimer. So you know that the D-dimer is basically fibrin degradation product or FDP. This is basically a small molecule. Uh, if we talk about a small protein fragment which is present in the blood after a fibrin clot is degraded by the fibrinolysis. So you can see there, this is the fibrinogen, and that's with the thrombins, it's combined, it's form a fibrin mash, and this fibrin mash with the support factor 13, that then cross-linked fibrin mash is formed, and then the plasma and other FDP combined to form a D-dimer. So it is so named because it's contained two D fragments of the fibrin protein joined by the cross-link. So if we talk about this, fibrin split product, which is basically produced when clots are broken down. So the clot is formed, immediately the clot begin to break down and the D-dimer is produced, and the elevated levels indicates a coagulopathy and the clot formation. Used to detect the major function, what is the D-dimer, and they're used to detect. It's also a marker for the venous thromboembolism, pulmonary embolism, stroke, aortic dissection, and disseminated intravascular coagulation. That's the DIC. So I have one good video. If you want, I can share with you. Let me share with you the video with you. It's very informative.
At the site of
So the voice is clear? Can you hear the voice?
vessel injury.
Yes, okay, thank you. So let me start again.
Site of vessel injury. The first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall. such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A, in combination with 5A, activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor 10A in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
So how this blood coagulation in vivo occurs? So you see that this is D-dimer is an fibrin degradation product. And then if we talk about the clinical application of this D-dimers, let's talk about some clinical application of the D-dimers. So the main clinical utilization of D-dimer is in DVT, that's a deep vein thrombosis, along with the pulmonary embolism, that's the PE, and the diffuse intravascular coagulation, DIC. So these are the three major utilization for the monitoring and the supportive prognosis of the D-dimers. So if we talk about the D-dimer, D-dimer in the deep vein thrombosis. Basically, DVT is the formation of a blood clot in the deep veins, like commonly in the legs or in the pelvis area. It's painful, and the swelling and the redness is observed, and an enlarged vein is in the affected areas is observed. So these are the initial symptoms of the DVT. That's an DVT. That's a deep vein thrombosis. But some DVTs have no symptoms as well. So what are the risk factors of this DVT? Recently, the recent surgery, the age factors, or an active carcinoma, along with obesity and the patient history and the family history of deep vein thrombosis. Is also an injuries and lack of the movement, hormonal birth control, and pregnancy and the period following birth, and the phospholipid syndromes are the high risk factor for the deep vein thrombosis. So if we go for a further about the epidemiological, that's in the global distribution of DVT. If we see the all DVT and the PE means the deep vein thrombosis and the pulmonary embolysis. You can see here the age factors after that. You can see after 50 to 59 years or greater than 60 years of age, there is an drastically change in the deep vein thrombosis annual incidence per 100,000 people. Along with that, the pulmonary embolisms or with and without deep vein thrombosis is also increased drastically after the age of 60. This is the cutoff usually. And then you can see that only the DVT alone is also increased that. So the age factor is also a major epidemiological distribution for the incidence on 100 per 100,000 globally. So if you go for the further about on the basis of guidelines, there is a lower limb DVT subsequent if there are clinical symptoms found in the patient with these DVTs. So the clinical probability assessment of level 2 modification well score is given that if the DVT is unlikely, you have to go for the D dimers. If the D dimer is negative, no DVT, no treatment for that for the DVT. But if it's a positive, and then the DVT is clinically likely on the basis of the symptoms, and the D dimer is also positive in case of even the unlikely DVT, that's an incomplete venous ultrasound is recommended. And then after the proximal DVT, that's then a treatment at least 3 months for the anticoagulant. So the DOS in the non-cancer patient, if there is no contraindication after the 3-month evaluation, venous ultrasound, risk benefit, and then they have to stop the anticoagulation. If it's still there, then they have to extend an anticoagulant therapy. Yearly evaluation is required. So in case of isolated distal DVT at a high risk recurrence or a low risk recurrence can be differentiated, and then the treatment for the 3 month with the anticoagulant therapy or a surveillance with the treatment is also required in some cases as well. So if we talk about more, these are the European Heart Journal Association. If we talk about the pulmonary embolism, what is pulmonary embolism? So basically, the pulmonary embolism is a blockage of an artery in the lungs. You can see here by a substance that has moved from elsewhere in the body through the bloodstream. So the symptoms are the shortness of the breath, the chest pain, particularly upon the breathing in, and the cough of blood. Sometimes a mild fever is also observed in the pulmonary embolism. So the risk factors are the carcinoma, the prolonged bedridden patient, the smoking, the stroke, a certain genetical condition in which that's the pulmonary embolism is progressed, and then an estrogen-based medication for the birth control and the pregnancy, obesity, and some surgery cases may lead to the embolisms. So if we talk about the pulmonary embolism epidemiological distribution on the basis of annual diagnosis in this incidence of PE per 100,000 population in Europe, US, and Japan, which has a more prevalence in especially in France. Its diagnosis incidence for the pulmonary embolisms in 100,000 population is 101 in France, in USA 104, and about the Germany, followed by the Italy, and in Spain, UK, and Japan. So mortality rate of acute pulmonary embolism according to the check in the European guidelines is listed here, like the clinical presentation of acute pulmonary embolism, and the mortality rate in unselected population is 11.4% at 2 weeks and 17% at 3 months. And the pulmonary embolism massive overall is 18 to 65%. So for the treated is approximately a 20% mortality rate. With the cardiogenetic shocks, that's a 25 to 30%. Resuscitation is 65%. And then the small pulmonary embolism and the pulmonary embolism is between 25 to up to the 1%. So this is the mortality rate of acute pulmonary embolism according to the European guideline and the Czech guidelines. So if we talk more about the guideline for pulmonary embolisms. So if the clinical symptoms or the suspicious for the PE, then the risk assessment using the Wells rule. So what are the Wells rules? If he goes to the low pre-test probability and then go for a D dimer, if the D dimer is not negative, so there is no probability of pulmonary embolisms or some sort of that. And then if the D dimer is positive, then the imaging is recommended, radiological testing for the supplemental testing to rule out the PE or some other coagulation disorders. So if the risk assessment using that shows the pre-test probability is intermediate, so then the D dimer helps negative stops the any further treatment, like the positive is also recommended for the imaging. For the high PTP, that's a pre-test probability, that's an immediate referral to the treatment, and the imaging is should be considered according to this guidelines from the Australian Family Physician journals, and on the basis of clinical suspicious of pre-test probability on low, intermediate, and high probability. So if we talk about DIC, the DIC stand for the diffuse intravascular coagulation. The diffuse intravascular coagulation is a condition in which blood clot form throughout the body, blocking the small blood vessels like this. Excuse me. The symptoms are basically the chest pain, the shortness of the breath, leg pains, the problem is speaking or the problem moving part of the body, and the blood in the urine, stool, or skin, and the organ failures are the early symptoms of diffuse intravascular coagulation disease. So if we talk about the risk factors, the sepsis, surgery, the trauma, carcinoma, and the pregnancy complications are the high risk factor for this diffuse intravascular coagulation. So in other clinical application, risk assessment for thrombus, anticoagulation therapy monitoring, and the detection of myocardial infarction and the cerebral infarction is important along with the auxiliary diagnosis of the cancers. So if we talk about the marketing analysis, the D-dimer test is very popular in North America, Europe, and Asia Pacific because the global D-dimer testing market, according to 212 and 22 test in the millions, is higher in Europe. That's 102.5 million, and if it's we consider in 2012, it was in the North American region is 91.6 million tests, and in Asia Pacific region it's a 41.1 million 2012. So the overall market for the D-dimer testing is increasing drastically in the Europe, and especially in the American markets, and the US market is increasing drastically. So if we talk about the global D-dimer test market by type, if we differentiate into a three major type of this coagulation disease, like deep vein thrombosis, that's the DVT, the pulmonary embolism, that's in PE, and disseminated intravascular coagulation, that's in DIC. So these, on the basis of three diseases, the D-dimer test utilization is more in the market, and then the D-dimer test market by the region is highest in the Europe, and then followed by the North America, the APAC, and the Latin America, and then there's the rest of the demand lower in the Middle East African. So if we see the global D-dimer test market by the end users, so the end user, you can see here the hospital utilization is the optimum, is the maximum. You can see then, and then the research institute has some low utilization of this D-dimers. And if we talk about the clinics, the major part of contribution of D-dimer test market is by either by the hospitals or by the clinic, and the diagnostics labs. These are the three major contributor for the global testing of the D-dimer in the market by the end users. So if we talk about the risk, on the basis of color coding, the low, medium, and high risk, you can see that the countries like China, Russia, Pakistan, India, Nepal, Bangladesh, Afghanistan, and the Australian regions are at a high risk in there, and the low risk areas are the North America, the Middle East countries, and the countries, European countries, are at a high risk. That. So if it goes to the about more related to the pack size, that in a D-dimer, we have two generation analytes. The first generation analyte is also available in 100 tests and 50 tests. The same with the second generation of 100 tests and 50 tests. The principle we based on a sandwich principle, and the human plasma is recommended for the testing of D-dimer. The sample volume is just a 20 microliter, and the assay time is just 15 minutes. And the 2-point calibration calibrators are available along with the reagent free of cost. But in the first generation kit, there was only one level of QC was available. But in the second generation of kit, we have a two level of quality controls for low and high value of detection. Otherwise, the customers can use the third party quality control also for the D-dimer. The calibration interval in the first generation was 1 week, but now that's an improved. In the second generation, it's up to a 28 days onboard calibration stability. But using the good laboratory practices, the customer can enhance the onboard stability of this calibration interval. So the measuring interval is between 0.05 to 100 microgram FEU. That's an fibrinogen equivalent unit per ml. Is in the older version. That the new version has a 0.25 250 to 100 micro G FEU per ml. So the onboard stability is 1 month. In all cases, either the 50 test pack size or 100 test pack size is available in the market. So if we compare the method of different immunoassay with this automatic systems, like if we compare with the latex or ELISA, the chemiluminescence the technology has a greater advantage of higher sensitivity and the quantitative and the fast and easy operation, and then in terms of reliability. If we talk about the ELISA, they have a high sensitivity and quantitative advantages, which is more similar to the chemiluminescence immunoassay technique, but the challenge is the complicated operation, the TTS procedures, and the expertise levels are required, and the long time testing cannot meet the need of emergency. For in the emergency cases, if the patient is bleeding and the fibrinogen degradation protein we want to rule out through the D-dimer test, or especially in the COVID situation when the patient need the monitoring of D-dimer periodically, the best choice for the clinical laboratory was a CLIA technique rather than the ELISA. If you talk about the latex, they are fast and easy, but due to the low sensitivity and the qualitative and semi-quantitative analysis, they have a big disadvantages from this point of view. So that's why, as of today, chemiluminescence immunoassay technique is much, much better than ELISA and the latex technique. So if we compare with the Maglumi D-dimer along with the other commercially available D-dimers, in comparison with the samples, we have found that the regression value is 0.989, which shows an excellent correlation between 0 to 60 values. So she gives you the microgram FEU per ml value. It shows an excellent correlation with the commercially available D-dimer assay. So if we talk about the question answers, in this question answer, if we ask what is being tested by the D-dimer assay. So as you know that the D-dimer test is done with the plasma. So it is very important during the installation of this assay to any customer side, the sample type plasma is recommended. And the D-dimer is one of the protein fragment produced when a blood clot is get dissolved in the body, and it is normally undetectable and detectable at very low levels, or you can see that in a very low level and the body is forming and breaking down the blood clots. Its level in the plasma can significantly rise as well, and then you can use this test for this process. So the elevated indicator indicates the clot formation, and if you use to predict the major bleeding after the VTE, can be used to monitor the treatment of effective during elevated about the 1500 nanogram per ml and associated with the VTE, and also predict the disease severity and not long-term outcomes. So if we go to the blood coagulation in vitro, that how the platelets during the cut situation, that's the tissue factors, and then the activated plats activate the platelets, and then the coagulation initiation phases start with the different coagulation factors, and these coagulation factors helps to improve to the amplification phase. And in this amplification phase, prothrombin and the thrombins are produced, and then it's converted to a fibrin and fibrinogen. And these fibrin and fibrinogen stabilize the cross-linked fibrin clots. And along with the fibrinogen, it's activate the 13A and 13 factors, which helps for the clotting process that we have seen in the video as well. So if we go for another questions about D-dimer order, when is the D-dimer is order? So you know that the D-dimer testing is often ordered when someone goes to the emergency room and has symptoms of chest pain and difficulties in breathing. So the D-dimer is especially useful with the healthcare practitioner, and they think that something other than the deep vein thrombosis or a pulmonary embolism is causing that symptoms. So just to rule out that the DVT and the PE cause if there is occurs on the basis of the D-dimer value, and it's basically a quick and non-invasive way to help out the abnormal or excessive clotting if occurs at the underlying cause for this clinical symptoms of chest pain and difficult in breathing. So the another question about the D-dimer is, what does the test results mean? So the normal or a negative D-dimer results, which the D-dimer level is below the predetermined cutoff threshold, that means it's the most likely that the person tested does not have an acute condition or a disease causing abnormal clot formation and the breakdown. In mostly the most health practitioner agree that the D-dimer is the most valid and useful test done for the people who are considering at a low risk for the thrombosis. So just to also for the low risk thrombosis patient bleeding rule out, that can be done by this testing as well. And this test is also help out to plotting the cause of the symptoms. And then it's very much important test for the coagulation related test. So in this position, we have discussed about the D-dimer. So if you have any question, you can ask. Otherwise, we have to move to the next presentation. Any question? Okay. So so the next presentation is about okay on meglumia. Okay. So Artem Urin, would you like to share with me the comparative data? And it's more important that the testing of D-dimer is sensitive, but it's not so much specific about disease. So this is the terminology that we use in for the D-dimers. This is very sensitive test. It gives out the rule out the any bleeding, but it's not very specific to rule out that. So the further supplemental testing and the clinical symptoms and the finding is more important along with this testing of D-dimer. So if you have any data for having a comparison, comparing the D-dimer, Meglumi D-dimer with any ACL top on analyzers, so please share with me so we can discuss, right? Thank you. Okay, thank you. Thank you very much, Artem Urin. Thank you. So the next presentation is on cardiac markers. So in cardiac markers, we have a very comprehensive menu which is HFABP, myoglobulin, cardiac troponin I, high sensitive cardiac troponin I, and CKMB. So let's start with this presentation. In this presentation, we have 4 parts. The first part contains about, let me share with you, the introduction about the cardiac markers and the individual clinical utilization of these cardiac markers and what clinical symptoms may lead to for that and what are the utilization, not only to diagnose the myocardial infarction or the heart failure, it's also used for the prognosis in some cases. And if we talk about the McLuhan cardiac markers, what are the solution provided by the SNIPE from the McLuhan platform, and we will discuss about the competitive intelligence between the other competitors and the McLuhan SNIPE cardiac markers. And in the last, we will discuss about the marketing facts about the myocardial infarction. And this is one of the biggest reason of global health burden, which is a myocardial infarction, that's an coronary heart failure diseases still in the world. So let's start with the introduction. So in introduction, if we talk about CK, as you know that there are basically is an enzyme which is catalyzing the reversible transformation of creatinine and ATP to create the phosphate and ADP. So this dimeric enzyme consists of 2 units, CKM and CKB. So in some cases, they have 3 isoenzymes like CKMM, CKBB, and CKMB. So CKMM is the dominant form found in the all tissue, and due to some muscular dystrophy, that CKMM is raised. So if we talk about CKBB, it's basically present in the brain, kidney, and gastrointestinal tract. It's any damage occurs in that area that may lead to increase the CKBB value. The CKMB is only found in the heart and the skeletal muscles, small intestine, diaphragm, uterus, tongue, and the prostate as well. So about 20% of the total CK in the myocardium is the MB form. So it's given a sensitivity and a specificity in the diagnosis of acute myocardial infarction. So when the creatinine has an creatine kinase, which convert into ATP to the ADP and convert into a phosphocreatinine compound, and then it has to create a creatine kinase, and then this creatine kinase is of 3 types. So the specific cardiac marker is CKMB. So if we talk about the CKMB, this is about that. The second cardiac marker is MB, that's a stand for the myoglobulin. So the myoglobulin is basically is an iron and oxygen binding protein and present in the heart and the skeletal muscles of human, and is a molecular weight of 16.8 kilo delta. So this is a structural of myoglobulin, and it's not found in the tissue, and other than the muscle, it can also be present in the bloodstream as a result of muscle damage. So you can see that the structure of the muscles fiber, you can see here the sarcolemma, transverse tubulars, and sarcolemma glycogen and the myoglobulins are present, and the mitochondria are present in it. So this myoglobulins is another cardiac markers. So if we talk about the troponin is basically a regulatory complex of 3 protein subunit. So these subunits are the thin filament of the myocardial contractile apparatus. So the troponin complex may be troponin I, troponin C, and troponin T. So the actin and troponomycin combine, and then they produce that. So the troponin T, basically a tropomycin binding component, molecular weight of 21 kilodelta, and the troponin C is a calcium binding component, and the troponin I is a inhibitory component for molecular weight of 37 kilodelta. So the kinetics of this troponin, that the release of troponin T and troponin I after myocardial damage are as follows. Like the level of troponin T and I start increasing 4 to 9 hours after acute myocardial infarction, and the peak is received at 12 to 24 hours later about that. So they can remain elevated up to the 14 days is an elevated value for that. So the specific marker is troponin I. If we talk about the troponin T, they have some diurnal variation in chronic kidney disease, and the interference of biotin is also may play a vital role for the false negative results for the troponin T. So if we talk about more about the other markers like HFAB, so this is basically uh, hard fatty acids binding proteins. They are basically a small cytosolic proteins, which is 15 kilo delta weight, and they have a high concentration in the myocardial tissue. So only can be detected in the plasma urine after the myocardial injury, and these hard fatty acids binding proteins are also a specific marker for the myocardial infarction and other cardiac heart failure diseases. So when the myocardium is injured, this lower molecular weight cytoplasmic protein, which is called HFABP, release in the blood circulation, and this blood circulation level of FABP increases in the blood and can be detected after the 30 minutes. So this is also a more specific cardiac marker for the myocardial infarction. So if you go for a clinical application, so for the coronary heart disease, you know that there's basically a in a myocardial infarction, the clinical manifestation is basically a narrowing of the coronary arteries. So how these coronary arteries becomes narrow? The main reasons are due to the deposition of plaque or some lipids, and then they may lead to some narrowing of these coronary arteries. And this is also leading to the imbalance between the functional requirement of the heart and the capacity of the coronary artery to supply blood and oxygen. So heart need a more pressure to pump the blood through this arteries balance goes to that arteries to the different organ, as in the consequences the heart muscles are damaged, which eventually becomes the clinically apparent with the cardiac symptoms. So the clinical symptoms for the coronary heart disease is an unstable or unstable angina pectoris, and then the myocardial infarction, the cardiac arrhythmias, the congestive heart failures, and sudden cardiac death are few the clinical manifestation of this coronary heart disease. So if you go for acute myocardial infarction, as you know that in the normal blood vessels, here these are the normal blood vessels, and these are the vessels with the plaque, and these are the blood flow interrupted in this artery, and then the local necrosis due to the artery may leads to the blockage, and then this artery has a myocardial necrosis expand, and then it's lead to the acute myocardial infarction. So this is acute myocardial infarction is the most common disease in the developing countries, and it's also known as heart attack. So when occurs, there is a sudden block in the blood flow, and one or more of the coronary arteries. This cut off blood supply to the part of the heart muscles and causes necrosis. So this necrosis, massive cells death, and the permanent damage may lead to the heart attack. So this is about the acute myocardial infarction. So if you go for a clinical application, then the universal definition of myocardial infarction, according to European Heart Journal. So they have detected the rise and the fall of the cardiac biomarkers, preferably troponin at the 99th percentile of the upper reference limit, together with the evidence of ischemia with at least one of the following. For the myocardial infarction, there is an ischemic symptoms if they have ECG changes along with the ischemia and the left branch block, and they have a development of the pathogenous Q wave in the ECG imaging evidence, the loss of viable myocardial, and the wall motion abnormalities is also an imaging evidence which which also help them to rule out the myocardial motion abnormalities. So these, with the supportive the imaging evidence, along with that, they helps to rule out rise or fall of the cardiac markers can be monitored through that process, according to the European Journal of Heart Journal. So these are the few famous people who died of the heart attack, like James Gandolfini and Luther Vandross and the Rebecca Speakings. They died at a very young age, and they all have died due to the coronary heart disease, like myocardial infarction or the heart attack, some cases. So, if we talk about the risk factors, the signs, early signs, and their analysis is more important to avoid any heart disease or sudden myocardial infarction or cardiac heart failures. So, the physical activities which contribute up to the 20 to 30% reduction in the coronary heart disease are like if the person is having a smoking habit, they have a using alcohol consumption, they have a dyslipidemia, they have a diabetes mellitus with the hypertension, obesity with the body mass index, and the age factors. About 80% of the heart disease occurs in the people age between the 65 and the older. So this is important. Along with the age factors, these factors play a very vital role for the high risk for the heart disease. If we talk about the genders, the men tends to be have attack earlier in the life than the woman. So this is an alarming situation. And the women rates of heart attack increase after the menopause, but not equal to the men rates. So still the men's are at high risk of myocardial infarction or the heart failure rate as compared to the women. So if we talk about the prevalence rate of modifiable risk factors in young versus the old patient, which are hospitalized for the acute myocardial infarction, by the prevalence of the modifiable risk factor in terms of percentage wise. If we review the different age factors, like men between 18 to 44 years age, the woman between 18 to 44 years, the men between 45 to 59, and the woman between 45 to 59. So the gender specific and the age specific evaluation or the prevalence rate or rate of the modifiable risk factors in a comparatively young and the older patient hospitalized for the acute myocardial infarction, it reveals that the risk factor is number one is the hypertension, and then they have followed by the dyslipidemia and the smoking, along with that the diabetes mellitus and the obesity, and their small cause is also by the drug abuse as well. So these are the risk factors on which prevalence rate of modified risk factor, which may lead to the myocardial infarction. So if we talk about the key factor according to the WHO guidelines for the cardiovascular disease, that this is a fact about the CVDs are the number one cause of deaths globally. So the more people died annually for the CKD more than any other case. So the number one cause of the natural deaths still globally is CVD. So it's according to the WHO data, this is estimated that around 17.9 million people died from the coronary vascular disease in 2016, representing 31% of the all global deaths. Of these deaths, and the 85% are due to the cardiac attack and the stroke. Out of 31% of global deaths, 85% are due to the heart attack and stroke. So over 3/4 of coronary ward disease take place in low and medium and middle income countries, and this is an also indication that the middle income countries people are not health conscious in terms of their monitoring and in terms of their health issues. So out of 17 million premature deaths, which is between the age less than 70 years of age, due to the non-communicable diseases, 82% are in a low and middle income countries, and 37% are caused by the coronary vascular diseases. So this most cardiovascular diseases can be prevented by addressing the behavioral risk factors such as smoking, unhealthy diet habits, and definitely the obesities and the physical inactivity. That's why now these days the doctors recommend that if you have a 30 minutes brisk walk, it's enough for you to keep you healthy for the longer period. And then the harmful usage of the alcohol using the population wide strategies are the most behavior risk factors include that. So if we talk about the people with the cardiovascular disease, they have a higher cardiovascular risk due to presence of one or more risk, either the tobacco use, unhealthy diet, obesity, or physical inactivity and alcohol consumptions. On the basis of that, one more risk factor is also there in the presence is due to the hypertension, the diabetes mellitus, hyperlipidemia, and also publish other established disease. So they need to be early detect and manage using counseling and medication as an appropriate according to that to make keep their health, the heart health in a better way to prevent from this cardiovascular disease. So if we talk about the top 10 global deaths, cause of deaths, according to 2016 data of WHO, in a millions that about the ischemic heart disease. It is almost 9.6 million people died globally. This is the natural death process in which caused by the ischemic heart disease. Around 5.8 million people died due to the stroke globally, and which is other followed by the chronic obstructive pulmonary disease. So it is very much important during these any clinical symptoms. You have to rule out either this is coronary heart failure disease or some pulmonary disease. Is differentiation is also important. For the low respiratory infection, there are death rates around 2.5 million people across the world. And the Alzheimer disease, tracheobronchus, lungs cancers, and diabetes mellitus, road injury, and diarrheal disease, and tuberculosis are also one of the major cause of global deaths in 2016. And this global deaths data is shared by the WHO. So if we talk about what are the solution provided by the SNIPE from the Megalomy platform. So as you know that the cardiac markers. So in the cardiac markers, we are using these tools for the diagnosis, and not only for the diagnosis, we are also use some assays for the risk stratification when the patient have a chest pain or suspected acute coronary syndromes. There are endogenous substances released in the circulation when the heart damage or stresses occurs. So what are these cardiac enzymes or a cardiac proteins released during then when the heart is damaged or is. So the first marker is the aspartate aminotransferase. This is an enzyme. Lactate dehydrogenase. This is LDH, and the creatine kinase. This is and the CKMB. So the CK and CKMB are considered as and along with the AST and LDH is the cardiac markers for the detection of some cardiac injuries. And along with that, there are some cardiac proteins. So these cardiac proteins are myoglobulin, the troponin D, troponin I, high sensitive, complement troponin I, and then HFAB. So these are the markers which act as a cardiac protein to rule out the different disease. So if we compare the SNIPE solution for cardiac markers, yes, we have a very comprehensive menu. If you talk about the cardiac marker CKMB, yes, we have a solution for CKMB. We have a myoglobulin along with the cardiac troponin I, high sensitive cardiac troponin I, HFAB is also an addition, is a great addition in the SNP cardiac marker menu. So if we compare with the other brand in the market like Roche, Abbott, Siemens, Bachmann, and the Biomurix, they have the CKMB. All these companies, they are offering the CKMBs, the myoglobulins test, and the complementary troponin I, while HS troponin I is not available with the Roche, but they are also available with the Beckman Coulter. So as of today, high sensitive cardiac troponin I is also available because there's a difference between conventional cardiac troponin I and high sensitive conditional troponin I. These values are 95 percentile and less than 10% CV. And the third requirement is the early detection of myocardial infarction using this high sensitive cardiac troponin I. So we have a very rare parameter. This is HFA-AB. This is a unique marker that we have. Only the competitors we have is a Roche in the market. So if we have a comparison about the cardiac marker characteristics of the different cardiac markers, like these are the hours and the post-pain situation and the release of different cardiac markers. So if we share the cardiac markers like CKMB within the 5 to 6 hours, the value is increased and the peak value is acquired at the 10th hours. And then the most important so the most important factors about the cardiac marker, which is an earliest marker, is the HFAB. That's the binding protein, which is used as a cardiac marker for that. And the second markers you can see about that myoglobulin, which has been acquired in early hours of myocardial infarction or the coronary heart failure disease in that case. So the CKMB and the conventional cardiac troponin I has the linear race with after some specific time, after 8 to 10 hours value, they have a clinical significance. If we talk about other analytes, which is high sensitive, we will discuss in number next slides. So if you go to further, for the characterization of different cardiac markers, if we have the peak value on the basis of their levels, that's HFAB is the first detection is at 0.5 hours as compared to the other markers. So this is the earliest marker detection for this patient. If we have the myoglobulin, which is 1 to 2 hours, the CKMB after 3 to 4 hours, the troponin I conventional is 4 to 6 hours, and the troponin T is 4 to 6 hours. But there is some limitation of troponin T as compared to the troponin I. Usually in the market, it is reported that the troponin T is superior than the troponin I. But practically, the troponin T has some disadvantages. That's why the troponin I is more reliable as compared to the troponin T. And in this case, according to the IFCC guideline for the high sensitive, our assay is also meet the requirement of a high sensitive troponin I, right? So we have also a high sensitive HS troponin I also is available. So the best is about the peak level for the high sensitive troponin I is between 4 to 6 hours. You can rule out the myocardial infarction, rule in and rule out the myocardial infarction of patient. So here you can see that the first detection is good in HFAB, and then myoglobulin with the cardiac troponin I, which is a high sensitivity, is recommended right now. So the peak level will be acquired for these cardiac markers between 6 to 8 hours, 4 to 8 hours, and then go on. If we talk about the time to be normal after some cardiac injury, it goes to be a normal after 12 to 24 hours, and the myoglobin value is between 0.5 to 1 days. It takes to almost 24 hours, it's a 12 to 24 hours. And if we talk about the CKMB, it goes into a normal value between 2 to 4 days. And if we talk about the cardiac troponin I, it takes 5 to 10 days to be normal as compared to the troponin T of 5 to 14 days. So if we talk about the specificity, the specific advantages in early acute myocardial diagnosis and the myoglobulins. This is non-specific. If we talk about the CKMB, they have high specific, not good as compared to the troponin I. The complement or a cardiac troponin I has a specific in early acute myocardial infarction, but the disadvantage for the AMI diagnosis specificity is now ruled out, and now they have launched the high sensitive troponin I. If you talk about the troponin T, they also raise in the acute coronary disease and in the sclerosis cases and in the renal disease with the skeletal damage is also may lead to the troponin T elevation levels in the patient. So it will be difficult to correlate with the troponin T, while the troponin I is the best in the class choice for the myocardial infarction, and this for the troponin I high sensitive myocardial infarction rule out is best in the class. So give me 1 minute, so I have to take one picture. So, okay, so let's move to the CKMB. So you can see that the CKMB here is a marker for the diagnosis of potential reinfarction. So, excuse me. So this CKMB is also a diagnosis for the potential reinfarction, and then it remains elevated in plasma less time than the troponin, and is for the indirect assessment of the extent of the myocardial necrosis. You can see here the isoforms of the CKMB is here about that, and then that can goes down. But the troponin T values elevate more frequently as compared to the troponin I, but they have some limitation of troponin T, and the CKMB and total CK with the myoglobulins have their some peak values between 11 to 16 hours. Here you can see here, and in the troponin T, after 18 to 24 hours, they have a peak values is received. So if we go for further about the potential reinfarction of myocardial infarction, we can review the assay-wise classification. Like we have a CKMB 2 generations, the generation 1 CKMB and generation 2. We both have a 100 test pack size and a 50 test pack size for this assay of CKMB from the McLuhan platform. The sandwich based on a sandwich principle. In the second generation, we have an improved with the human serum and plasma both, and the sample volume is reduced in the second generation along with the test time is just 15 minutes. So this is also an edge for these emergency testing, that our incubation time is very low. That's in just 15 minutes. The first results will give you that. In the second generation, as compared to the first generation, we have an edge. SNIPE is providing free of cost 2 level of quality control, which meet the minimum requirement of the quality standards to check the assay performance. So if we more talk about the calibration interval, before that, in the first generation, the CKMB kit has just uh, uh, 2 weeks or 14 days stability, while in the next second generation essay, either the 50 test or 100 test, their onboard stability is 28 days. So you know that limit of blank, limit of detection. So on the basis of limit of blank and limit of detection, we have a very broad measuring range for the CKMB from 1.0 to 500 nanogram per ml. So within the run precision, this is called a simple precision, and between the run, which is called a complex precision. The complex precision is improved in this assays from 5.53 to 3.02, and then complex precision from 5.30 to 2.48, which shows that the next generation assay of our CKMB is improved and much, much better than the first generation. And if we compare with the other competitors like Roche, Abbott, and Siemens, we can review that. So if we compare our first generation CKMB during the evaluation of Maglumi CKMB assay versus the available CKMB available in the market. So on the basis of 124 samples run, the regression value is 0.98, which shows the excellent correlation of our SNI Maglumi CKMB assay versus the commercially available CKMB assays. So this is a good correlation between the two different assays of CKMB. So if we talk about the myoglobulin, which is used for the early diagnosis as combined with the cardiac markers. So if we talk about the day after the onset of acute myocardial infarction, so this is a 0 day, this is a few hours, and this is day 1, day 2, day 3, day 4, day 5, day 6, day 7, and day 8. So this is a plot which shows the appearance of the cardiac markers in the blood versus time after onset of the symptoms. So on the basis of this data of a multiple of the cutoff limits and the day after the onset of acute myocardial infarction, they said that the one heart or the skeletal muscle is injured, is released into the blood, and increased myoglobin level can also be measured within a few hours following injury. So this A factor has showed you the early release of myocardial infarction after the acute myocardial infarction, and the cardiac troponin after AMI, the cardiac troponin after the unstable angina, and the green one is CKMB after acute myocardial infarction. So within 1 day or within 6 to 8 hours, it is helpful to diagnose with this cardiac markers for the condition of different patient. You have a file for the test. Yes, I have a file for the detection range and the test execution time and the sample volume. I will show you in today presentation. By ending this presentation, I will show you. Okay, Artem, you didn't? I will show you, right? So if we go further about the myoglobulin, so it's an best indicator for the succession or the failure of a reperfusion attempt. Like myoglobulin reperfusion, when the intravenous thrombolysis is used for the acute myocardial infarction, it is very much important to determine the coronary reperfusion rapidly or non-invasively, so that the further treatment can be initiated or the not. That's the myocardial useful for assessing the cause of the myocardial reperfusion. So this is very much important case in the myocardial perfusion. And if talk about the myoglobulin specification, we have two generation for the myoglobulin assay. The first generation and the second generation, they both have an availability of 100 tests and 50 tests. The test principle is based on a sandwich principle. In the second generation, we have improved the sample type. Not only the serum, the plasma is also recommended, and all the samples tubes which are related to the yes, okay, thank you. So all the related tubes which are related for the plasma, they are also mentioned in the package insert as well. We also improve the sample volume from 20 microliter to the 10 microliter. And the assay time is just 29 minutes. We have providing free of cost calibrator to perform a 2-point calibration. And as you know that the master calibration of 10-point calibration that I can be acquired by the RFID barcode of the each reagent when you read it and place it on the reagent area. So if we talk about the control in the second generation control, we have a 2 level of QC, which is low and high value of QC to monitor from the both aspect of the assay performance in terms of quality standard. So if we talk about the limit of blank and the limit of detection, we have improved in the linearity. If you talk about the linearity, the linearity or the second generation of myoglobulin kit is 1 and 4,000 nanogram per ml. So beyond this 400 nanogram, 4,000 nanogram per ml, there is an automatic dilution is recommended if required. So within the run precision, it's a less than 6.26, and between the run, it shows the simple precision and the complex precision according to the CLSI guidelines. The precision is improved also in the second generation of myoglobulin assay, which is 3.19 and 1.58. So if we compare the Meglumi myoglobulin assay results in terms of nanogram per ml with the commercially available other myoglobulin assay, so it's on the basis of number of run, like 139 samples were used to study in this survey, and then they have compared with the commercially available myoglobulin assay. The regression value is 0.978, which shows an excellent correlation between the commercially available myoglobulin assay versus the Meglumi myoglobulin assay of first generation. So as you know that the second generation is it has some improvement in terms of methodology and then in terms of the linearity. So if we talk about the troponin, so as you know that the troponin is more specific in troponin T cause, and the troponin T is also found in the muscles as well. And you know that the troponin I has a more various established cardiac markers, which shows some increase in peak level and return to the base value about that. So according to the clinical chemistry, immunology, and laboratory quality control book, and the next certification in clinical practice. There's an cardiac markers like a myoglobulin, CKMB, and troponin I and T. Their increased value is the early markers, the myoglobulin, which is 1 to 4 hours, while followed by the CKMB 4 to 9 hours, with the conventional troponin I and T is 4 to 9 hours. To meet the early increased levels or the detection levels of the cardiac markers. Now the new assays, that's an troponin HS, which if the assays meet the requirement of IFCC of 95 percentile in the normal population and the less than 10% CV is also the two criteria for this high sensitive troponin I. So if we talk about the myoglobulin to rule out the cardiac as a cardiac marker, the increased value is observed in 1 to 4 hours, and the peak value is observed between 4 to 12 hours. So if we return to the baseline, when these values goes down to the decreased levels after 24 to 36 hours, and it's an earliest markers, but non-specific with the negative predictive value, that's also a drawback for the myoglobulin. If you talk about the CKMB, its peak level is achieved after 24 hours, and they start increasing after 4 to 9 hours duration. There's the increase, optimum increases observed. This is the gold standard from before troponin was introduced, and it's mostly found in the cytosol, but may also increase in the non-myocardial more myocardial infarction situation as well. So that was a gold standard before the troponin I and troponin IHS launch. So if you talk about the troponin I, it's an increase between 4 to 9 hours, and they have achieved between 12 to 24 hours the peak value of troponin I or troponin T, and it's also remained to the baseline, and it comes to back to the baseline after 7 to 14 days. It's the most specific marker which is found in this small amount in the cytosol, but also mostly in the sarcomeres of the cardiac myocytes. But both early and the late markers, and the troponin T is less specific than the troponin I, because troponin T is also found in the muscles as well. So this is about the troponin I and the edge of troponin I versus the troponin T, and then the clinical utilization of that. If you talk about the cardiac troponin I and the acute heart failures, so according to the patient days in the hospital and the cumulative mortality rate in terms of percentage, the patient with the troponin positive, the days mortality according to the number of days in the hospital and troponin status. In this presentation, the patient value is less than 0.001 by the long rank test, and dashing lines are showing that a 95 percentile confidence interval. So the patient presenting with the acute myocardial infarction, sorry, acute myocardial infarction and a failure, and have a positive troponin status, which also shows you the high risk concordance for that. And as compared to the troponin values are negative. And if we talk about the hospital mortality according to in terms of percentage according to the troponin I quartiles, so you can see that the measurement of troponin I adds an important prognosis information for the initial evaluation of the patient with acute heart failure, and should be considered as part of the early assessment of the risk. So this is about the cardiac troponin I and acute heart failures history. So if we go for a troponin I specification, so we have two assays like troponin I and troponin first generation and the second generation. Both have a 100 test and 50 test pack size. They have a sandwich principle, but in the second generation, we have improved from only serum to the serum and plasma. Both sample types are recommended, and the specific plasma anticoagulant tubes are also mentioned in the package insert. So if it goes to the sample volume, we have a sample volume of just 100 microliter, along with within just 15 minutes, the system will give you the result of troponin I. We have a 2-point calibration, which are free of cost with along with each reagent. In the second generation, we have a 2 level of QC, and the calibration stability is 2 weeks. So on the basis of limit of blank and limit of detection, which is improved in the second generation, we have a linearity of 0.015 to 15 nanogram per ml. So if we talk about the simple precision and the complex precision, we have improved in the second generation of simple precision is a 4.88 as compared to the 6.98 in the first generation. We have also improved the complex precision coefficient of variation, which is 2.44 in the second generation of troponin I as compared to 3.17 of the first generation of troponin I. So this is an edge in the second generation of cardiac troponin I, that's in CTNI, and the second generation. So if we compare the myocardial infarction markers, we have a comparison for the CKMB, myoglobulin, and the troponins. So the biggest advantage of CKMB is in fast results, right? The test availability is very common from the different instrument platform. The CKMB analyte is available. And the SNI Meglumi has the most comprehensive menu for the cardiac markers. So it can detect early infarction as well. So the disadvantage, this cardio specificity is low because in some cases, some other organs are also releasing the CKMB. They have a low sensitivity and they are not very useful for predicting cardiovascular risk stratification. So the recommended as an alternate option if the troponins are unavailable. So the patient can or a physician can refer. In case of troponin I, HS is not available, they refer for the CKMB. If you talk about the myoglobulin, they have a big advantage of the fast results and the availability from the test menu across the SNI meglumi family. We can detect early infarction, but can it not be can detect also the reperfusion also. So the disadvantage is in cardio specificity and their overall sensitivity for the infarction, unable to detect the small infarction is very overall low. It's not useful for predicting a cardiovascular disease, and they do not use as a single marker. It has to be used with the other cardiac markers and the clinical symptoms of the patient as well. So if we talk about the troponin, these are the useful in the guideline therapy according to the American Heart Association. They have a fast results test menu is available. They have a diagnostic sensitivity improvement plan. The cardio specificity is more reliable in troponin I versus the troponin T, and it's also act as a predicted cardiovascular risk factor analysis. So it commonly used in the clinical practice, and they have a limited usefulness in the detecting early infarction. It should be measured as an currently recommended. So this is about the markers of cardiac advantages, disadvantages, and the recommendation from these guidelines. So if you go for a high sensitive troponin I, HS, HSCTNI. So, according to the European Society of Cardiology and the American College of Cardiology, they have jointly recommend using a diagnostic cutoff point at 99 percentile of the reference population with the optimum coefficient of variation of coefficient of the less than or equal to 10. So this is the criteria. If any troponin, either the T or I, meet this criteria of European Society of Cardiology or American College of Cardiology, are called the high sensitive troponin I. So the IFCC, according to the guidelines, they classify these assays on the basis of this. So this troponin concentration, the precision of the troponin I is better than high sensitive is better than the normal conventional troponin I, and the high sensitive troponin I can be determined troponin with the lower concentration as compared to the required confidence interval as well. So this is about the high sensitive troponin I. If we talk about the high sensitive troponin I, time of conversion to the positive troponin I with the patient of myocardial infarction. So it has been proven that if we talk about the positive conversion that you can see here, this is high sensitive troponin I, and this troponin I ultra results was positive, that's 0.04 nanogram per ml, and before the conventional troponin I result is 66 of 103 patient, allowing the diagnosis of myocardial injury to be made earlier. So this is a great tool. Okay, so Artem, your question is what factor influenced the results? So which assay results? The troponin I results? The quality of biomaterial, taking medication, chronic disease. Yes. Yes, these are the factors which also have an impact on the medication. If the patient is on a medication, the chronic disease, again, the clinical correlation and the patient history required if the cardiac markers results are not concordance with the patient condition, current condition. So I'm just talking about the troponin T versus the troponin I. So the diurnal variation is also occurs in the troponin T, and in the muscular dystrophy case is also occurs have some evidences that I can show you in the next slides about the troponin I and the utilization of that high sensitive. I will share with you some factors. Sure. So this is the time of conversion in which that you can see that when the baseline specimens was obtained at 0 hour, and then it's okay. So the baseline samples was obtained at the 0 hour and then into 24 hours interval from 0 hour to 24 hours of patient with the myocardial injury. That's, you can see that that's the ultra results was a positive troponin I ultra sensitive, and before that this complement conventional troponin I results was in 66 of the 103 patient, allowing the diagnosis of myocardial infarction to be made earlier. So the 64% patient got more earlier result confirmation through this serological testing of high sensitive troponin I as compared to the conventional troponin I results. So this is the basically a relationship between the high sensitive cardiac troponin I and acute myocardial infarction. So if we talk about here, the cutoff for the conventional troponin I is 0.1 to 1 and 10. It's if it's a 0.1 value, this is a low small acute myocardial infarction, or maybe the early large acute myocardial infarction or myocarditis, or some shock CHF or subarachnoidal bleeding is also occurs. For the value, if you reach to the 1 value, it's a large AMI, myocarditis, or Takotsubo, or PE, or critical illnesses occurs. So if the 10, it's a very large acute myocardial infarction or myocarditis occurs. But the cutoff for the high sensitive troponin I is 0.05, which shows you the micro acute myocardial infarction, because it's early detect, help them to start the treatment for this early acute myocardial infarction, or maybe have some early large acute myocardial infarction along with the myocarditis, CHF shocks, the PE values, and hypertension, crisis, and the stable coronary artery disease. So the value between 0.010 and 0.005, it's a healthy individual was there, and then the stable angina, coronary heart failure, and then subclinical heart disease are also, these are the relationship of high sensitive troponin I versus the acute myocardial infarction. So if we go to the high sensitive troponin I specification, that we have two generation assays, the first generation and the second generation. So we have 100 test and 50 test pack size with the sandwich principle based on the human serum and in plasma. So we have a 100 microliter assay, and that just 25 minutes assay times gives you the results of emergency ED department patient. So we have a 2-point calibration in both first generation and second generation. And then we have introduced 3 level of quality control in the second generation of troponin I high sensitive assay. And the onboard reagent calibration interval is 28 days. So if we talk about the linearity is between 2 to 50,000 picogram per ml. And the within run precision is for less than 5.62, and the between the run precision is 4.92, which shows that we have a broad measuring range, and we cannot require no dilution. But for those patients who have comes the result is greater than 50,000, there is some dilution factors are recommended. I will share with you. For the high sensitive troponin I, it's, I think I remember as 1:2 or 1:5 dilution protocol is recommended for the high results if the cardiologist or emergency physician wants the exact results for the monitoring of the treatment of the myocardial infarction patient. So that's why we have a broad measuring aid, but still they need, we can provide this solution. So if we compare our one commercial high sensitive troponin I with the Meglumi high sensitive troponin I results, then we have found that they have an excellent correlation of the 0.99 value, and the number of samples is were at 258 samples. So this comparison were based on high sensitive troponin I assay in a picogram per ml versus the Meglumi high sensitive troponin I assay, first generation assay with the picogram per ml value. So if we go for multiple venous cirrhosis about the early marker of acute myocardial infarction, you can see here we have more options like troponin, CKMB, myoglobulin, and HFAB. So these are the markers which helps you to diagnose. You can see that the HFAB is also an early marker. It's released early and it's decreased early with the post necrosis situation, while the troponin has an early release and they have more stability as compared to the FABB. So it can be detected within the 30 minutes after acute cardiac event. So the FAB is an early cardiac markers. So the level of HFAB is start increase rapidly in between the 1 to 3 hours. This is then within the 1 hour up to the 3 hours that can be detected, and then it's reach its peak about 6 to 8 hours, and it returns to the normal after 12 to 24 hours. The quantity of HAB almost 10 folds higher in the cardiac muscles than in the skeletals. That's why it's an early marker for the acute myocardial infarction. So if we go further for HFAB, there's an comparison of several commonly used cardiomarkers like the high sensitivity about the myoglobulin, the conventional troponin I, CKMB, troponin T, and HFAB. So if we talk about these assays, especially the hard type fatty acids binding proteins, the high sensitivity of myoglobulin and the conventional troponin I along with the troponin T and the FAB is existing. While we talk about the specificity, the cardiac troponin TI and the HFAB has high specificity to rule out the myocardial infarction or as an act as an cardiac markers. If we talk about the prognosis value, the troponin I, conventional and the high sensitive, and the troponin T has also an rule has a best option for as a cardiac marker. So the overall conclusion for this comparison of commonly used cardiac marker is that with respect to the high sensitivity and specificity, and with in terms of the good prognosis, the troponin I HS is the ideal marker for rule out of cardiac myocardial infarction. So if we talk about and also along with the high sensitive myocardial infarction, there is also have a HFAB is an hard type fatty acids binding protein is also as a good marker for that. Okay, so Artem, as far I know, the troponin I HS high sensitive assay is also used for the risk stratification. So in some cases, they have a gender specific value. If the first baseline sample and the second sample after 2 hours or 3 hours The value, if its 10x fold is increased, it should be considered as a myocardial infarction. And if there is no symptoms of any chest pain or myocardial infarction, if the person is a healthy, they want to use their value for the risk stratification, and I will share with you in the next few slides. These are related to the other competitors, but it's not mentioned in the SNI platform. We have a high sensitive troponin I, but we need to improve the package insert of high sensitive troponin I as well. So if we talk about more, the sensitivity and specificity as a cardiac marker, then the other cardiac marker is an acute myocardial infarction. So the high sensitive troponin I and HFABs are the more specific marker for in terms of sensitivity, specificity, and the prognostic values as well. So if we go to some HFAB specification, we have two generations for this assay. Like if we talk about the 100 test and the 50 test pack size, we have a principle of sandwich. We have a human serum and in plasma. We have a sample volume of just 20 microliters, and the test time is just in 15 minutes. We have a 2-point calibrator free of cost available with that. And in the second generation of HFAB assay, we have two level of control and the calibration interval of 2 weeks. Along with that, we have linearity up to 360 nanogram per ml, and within the run precision and the between the run precision is significantly better than the other competitors. So if we talk about the comparison of our Meglumi FAB assay versus the commercially available HFAB assay on the basis of 100,038 clinical sample used for the correlation in terms of nanogram per ml value, you can see here that the overall the regression value is 0.97, regression value 0.968, and then this shows an excellent correlation of Meglumi HFAB BP assay versus the market available HFABP analyte. So this is an excellent correlation of our assay with the commercially available other competitors in the market. So if we compare this assay with the other market player, so in comparison, we have a Rendox, which has an immunoturbidimetric assay method with the Biotech's ELISA technique. So if we see that method principle, they are based on chemiluminescence and the sandwich assay. The Rendox based on immunoturbidimetric assay method with the latex enhanced technology, while the ELISA is enzyme-linked immunosorbent assays. And if we talk about the quantitative analysis, yes, all these three competitors, including the SNIBE like Rendox and Icolate Biotech, they have a quantitative analysis of HFA-VP assays. If we have a measuring range, it's up to 360 nanogram per ml, which is better than the Rendox. And in terms of ELISA, we have a less measuring range in terms of it's 250 in nanogram per ml. If we convert, because this unit is in a picogram per ml, so it's in 250 nanogram per ml. So we are also across the board, we have a broad measuring range for the HFAB assay. So if we talk about the sample volume, we have a reasonably good sample volume in both generation of HFAB assay. We have just automatic 15 minutes assay times, while the Rendox has the 20 minutes and the 45 minutes by the ELISA technique. So the incubation time is just 10 minutes. The Rendox is also 10 minutes, but the Biotech's incubation time is 37 minutes. The sample type is serum and the plasma is potassium sodium heparin or potassium dipotassium EDTA, while they have also a serum and dipotassium EDTA and heparin plasma is also recommended by the ELISA Heckwood Biotech and the Randox latex enhanced immunodermatometric assays. So, if we talk about the calibration frequency, we have a 2 weeks on-board calibration stability, while the calibration stability from the Rendox and other platforms are not available at the moment. So, if we talk about the stability and on-board, the 100 test or 50 test packet size can be utilized within the 4 weeks according to the workload the targeted customers can order the reagents on that. As compared to the other, they have also 1 month onboard stability of that reagent. So the test recommendation is about the small hospital is the troponin I test. And now these days, the high sensitive troponin I test is the ideal clinical testing for the myocardial infarction. If they cannot afford the price, the CKMB is an alternative option for the small hospital. For the medium-sized hospital, troponin I should be highly recommended as a routine testing. If possible, HFA-BP can also be recommended along with that troponin I assay. If we talk about the large hospital, we have a combination a test between the troponin I and CKMB and myocardial myoglobulin in the routine clinical testing. Meanwhile, the HFAB also is recommended for the emergency department, and the high sensitive cardiac troponin I is strongly suggested for the health sectors as well for the large hospital size. So if we go for market analysis, as you know that the number one cause of natural death globally is coronary heart failures, and the target population that people who are having a symptoms of a metabolic syndrome, if they have a chronic diabetes and they have a feeling of the chest pain and some other symptoms, they want to go for a screening, they will go for a testing for this cardiac markers. If the target utilization from the clinical symptoms of the myocardial infarction or CHF, the congestive heart failures, or ACS, the acute coronary syndrome, and atherosclerosis, and another condition in which the patient has an complication with the diabetes mellitus, hypertension, and they have a high risk factor of hyperlipidemia cases to rule out such situation, and the risk assessment analysis can be done by this way. So the target end users for these testings are the hospitals, and the lab for the health checkups are the most area where these testings can be performed, and the community medical centers where the screening of the patients are done during their clinic visits. So if we talk about the metabolic syndromes and the type 2 diabetes, which are the two most common disease in the population, and these two diseases are also a most important cause of coronary heart disease. So you can see here that the age-adjusted prevalence of coronary heart disease in the US population is over 50 years of age, and they're characterized by the presence of metabolic syndrome, and the type 2 diabetes was also playing a coronary heart disease prevalence is more, as this is a 19.2 in the type 2 diabetes, and the metabolic syndromes cases as well. In comparison with the metabolic syndromes, and the number types 2 diabetes is there also. So if we talk about the marketing, as a professional IVD manufacturers, SNIPE has a more focus on immunoassay. In the last 28 years, we have an excellent chemiluminescence immunoassay system brand, which is called Meglumi M series and X series, which are distributed throughout the world. And we are providing the more comprehensive details about the cardiac markers, and we have the broadest menu in that platform. So for the urine, we have to go for a few slides I would like to share with you. Just give me a 1 minute, so I will share with you some slides.